We know that about 70% of relationships that should be disclosed are either undisclosed or undiscovered, typically in a healthcare system.
All right. Well, Aaron, thank you for joining us. We've met, I think, before, but I first connected with this topic when you and a good friend spoke at the health law section meeting a couple of months ago, and you talked about conflict of interest policies and managing conflicts of interest, and then open payments data, and how some takeaways for what happens when physicians or other prescribers receive receive money from certain types of reporting entities and how that affects their prescribing behaviors. So I want to get into all that and talk about all those things. But first, what is Conflixis? I know you're the CEO, founder of Conflixis. What does Conflixis do?
Yeah, so we are a software and data analytics company. On the software side, we help basically any healthcare employer collect, understand, and mitigate perceived and real conflicts of interest. This is something that most organizations have to do. They have to go and ask, do you have any relationships that could expose our organization to a conflict of interest? So we help collect, manage, and understand that. And then on the data analytics side, we provide a lot of benchmarking information, a lot of contextual understanding of what those relationships mean. And that helps these organizations make decisions. I think historically, collection of conflict of interest has kind of been like, well, I send a form out, I hope it gets filled out, and then that's it. And
we
the truth
assume
is
if they
that,
didn't fill out the form, there's no conflict of interest, and so we're all good.
right. And we all know providers and folks who work in healthcare are busy. There's a lot of data out there. And so one of the reasons we came about is that we realized there were big gaps there, not just in like what was being reported, but then also finding out that the stuff that wasn't reported all the time, or even the stuff that was reported, was potentially creating a lot more risk. So honestly, we sort of have said in the past, to big organizations, if you're not going to look at your conflicts of interest data that you're collecting in a meaningful way to understand what it means to your organization, what risk it's causing, you probably shouldn't collect it at all, because you're just creating evidence of something that you are not going to deal with.
Just like we tell clients, if you're going to have a policy, you need to follow your policy. You're better off not having a policy if you're not going to follow it.
That's right. And I think, we're going to get into why open payments is interesting, but open payments is really it's just a window into sort of the size of the gap between what's really happening on the ground every day and what organizations that are exposed to that risk actually understand. And if we see a policy for a hospital and they say, well, we don't allow interactions with industry in our system, and then we look at the data, and the data says that they had $40 million of interactions in the past 2 years. That's a pretty big gap, both from like an understanding perspective, like you should at least have a visibility into this so you can understand the story of it. And then the second piece of that is, what are those interactions doing to your system, or what is the potential perception or story around those interactions from an outsider, from a payer's perspective, from the government's perspective, and from a patient's perspective?
Well, I think you kind of hinted at this. So in the healthcare space, and I know you do work beyond just the healthcare space, but when we say conflicts of interest, what are we talking about?
Yes. So it's a great question. So, and by the way, we only really do healthcare. That's
okay.
it. We do lots of different roles in healthcare. So for example, conflict of interest in general is a relationship. It could be a personal relationship. It could be a financial relationship that may call into question someone's judgment as it relates to their job. Right. So in healthcare, particularly, some of the major risks come from, is there a relationship that a provider has that relates to basically healthcare or medical decisions that are being billed to the federal government? That's the biggest risk.
So it might be conflict of interest between like the physician and a patient, is the physician being influenced to do something, or is the medical judgment being influenced in a way that may not be in keeping with the patient's best interest, and or is the physician being influenced to do something that might not be consistent with organizational policies or laws for Medicare reimbursement, those types of frictions between the medical decision making process and the best interest of the organization or the patient.
Right. And I think that there's a regulatory piece of this where it is, are the services and things that are being provided to the patient medically necessary and reasonable? Um, and then there's other questions of conflict of interest, which are more organizational conflicts of interest, which are sort of secondarily related to that. Is the hospital system buying and spending its money on devices and supplies and services that are serving the best interest of the hospital and its goals, whether it is a for-profit hospital or its margins or its operating margins, or quality, right? There's all sorts of things that touch that, and so conflicts of interest really touches all of that. And I think one of the important things to think about conflict of interest is it's a very interesting kind of risk, because you have the appearance of a conflict and then you have an actual conflict, right? So the appearance of a conflict is not very much different from an actual conflict in the absence of understanding the mechanism of the relationship. What do I mean by that? Well, if I'm sitting outside of a system and I'm a patient or I'm a payer, and I look at an organization and I say, well, gosh, the orthopedic surgeons at this hospital are taking $5 million from Stryker. What am I going to assume as a payer or as a patient, right? I'm going to think, well, that's interesting. Why is that? Why are they getting so much money? What is the purpose for that? Now, there's another side of that where providers will say that's actually not that much money. It's very normal. This is something that happens all the time in our industry. This is not important, right? But what's interesting is that from an outsider's perspective, they're going to be able to formulate their own story in the absence of contextual data, right? What you might do or know if you actually ask some questions and understood is you have a group of orthopedic surgeons at this hospital who are very accomplished. They're key opinion leaders. They are inventors. They are helping transform how knee surgery is done in our country, which has had a big positive impact on quality and cost. Right. And if you have that information and you understand these doctors are being compensated for that valuable work, right, then as a payer, as a patient, as a regulator, you might say, like, this is great. Actually, I want to go to this hospital because of this purpose. But in the absence of understanding that context, right, the trust level in healthcare right now between
Right.
patients and systems and between patients, the providers of healthcare, and the people who pay for healthcare is very low. And so,
Right.
unfortunately, the assumption is usually the worst, which is there's some kind of quid pro quo here, which exposes organizations to lots of reputational risk. It exposes providers to reputational risk, but also significant regulatory risk. But above and beyond that, there's a ton of research that shows that these payments do tend to impact behavior.
All right. So
They do tend
let's
to.
drill down into that, because part of managing the conflict of interest is first recognizing when there is a potential conflict of interest, rather, whether it's an actual conflict or a perceived conflict, you have to identify it. And I suppose there's got to be more ways to identify a conflict than just relying on the physician or the provider to report a potential conflict. There has to be the context that you mentioned, where you can go to some data and see if the conditions are ripe, or at least if conditions exist where a conflict of interest might occur. And that's
Right.
where open payments comes in.
That's right. So open payments is a federally mandated process by which covered entities, which is usually device and drug companies, have to report to CMS any transactions that they have with anybody who has an NPI, excluding some groups of NPIs, but it's physicians and PAs and NPs typically.
So
Um,
I want to give folks kind of an idea of what the breadth of this open payments data. Um,
it's quite
there
rare.
are there are reporting entities, those entities that have to report to CMS. They have to report certain payments, and there's different categories of payments they have to report. When those payments go to certain covered or
Covered
covered
entities,
recipients.
covered
So, kind of
recipients. Yep,
those three pillars dictate the type of data that's captured by CMS.
that's correct. And the data is quite detailed, and the data is accessible to anyone who wants to look at it. And the full data sets can be downloaded, but the breadth of the data is wide. So it's everything from a meal transaction, which might be $5, $10, to royalty payments, which could be millions and millions and millions of dollars, to ownership, to research. And so this is also what's interesting is that um, obviously there's rules and regulations around um, you know basically how conflicts of interest they shouldn't impact your medical decision making, but also research, right? So there's just a tremendous amount of data, for example, around research, and research conflicts are very important right now, just because of the healthcare leadership in this country and how we're talking about this stuff. But it is very common for folks who are doing research to also have unresearch related payments coming to them. So, for example, you might have a person who is conducting a lot of research for a big drug company and also acting as a consultant for that company, right? That's not inherently necessarily a conflict of interest. It really depends on like what's going on there. What's the
Sure.
consulting for? What's the research about? Are they related? Like there's a lot of detail that has to be gathered. But what we found is that typically when we look at conflicts of interest and open payments data, we can compare what's being disclosed versus what we see in the record, which is, I think, where you were going. And
Yeah.
we
So,
know that about 70% of relationships that should be disclosed are either undisclosed or undiscovered, typically in a healthcare system. Why is that? It's not because providers are trying to be sneaky or get away with something. Absolutely not. I think providers they want to report, they want to do the things they're supposed to do. But the problem is it's a lot of data, and it's a lot of searching for it and reporting it and taking it from one place and writing it in another, and it's just a pain.
I want to drill down into some numbers, but I want to give some context. So open payments tracks like three general categories of payments to the types of people you would expect: physicians and nurses and those who are making treatment decisions. And so those payments are like general research type grants, ownership and investment payments, and then a broad category is called general payments, which includes all the things that you would expect it to include, like travel and lodging and food and speaking engagements and honoraria and gifts and all those types of things.
Yeah,
Um,
yeah,
so let's
yep.
start breaking down these payments. How many physicians out there, by percentage, I suppose, are actually getting some of these payments from drug or device manufacturers?
Yeah, so it really depends on like the how you're measuring. So if you were to look at like every NPI, out there, that's a different answer than sort of like active physicians. There's varying sort of reporting of how much it is between like 30 and over 50% of providers have some kind of relationship, right? And that could mean a single lunch, and it could mean millions of dollars a year. Um, in terms of the research payments, there's kind of two categories of research. There's associated research payments, and then there's like research payments that are directly associated with that person as an MPI. It's actually like kind of vague what these mean. And then you get into ownership, which is reported annually, the same ownership data by these companies for a particular MPI. There's both like reported amount of ownership and then also reported amount invested, which is kind of interesting. There's a bifurcation there.
Mm.
And then you have general payments, which, like you said, is like food, travel, gifts, uh, repayment of a loan. But there are also some categories that are very common that are actually hard to. It's hard to understand what that's for. So typically, if we look at an organization, either the top category or the second category is something called payments for services other than consulting. Well, what exactly is that? Good question. So typically, it is like for attendance at a conference or speaking at a conference or engaging with some kind of marketing activity for a device or drug company. It could be many, many things, um, right? And there's a lot of that. There's a lot of that money, and that can be high risk. So if we look at the amount of that money that has been paid since, for example, 2020, it's almost doubled, right? I think it's somewhere in the high $400 million range now. Um, right? And so there's a lot of those interactions. And what we see is that even organizations that are pretty savvy about looking at their open payments exposure, they want more detail about what that means. Like, what is, okay, so you got a $10,000 check for payments for services other than consulting. That's not enough detail for me. Whereas, like, food and beverage, like, okay, so you had 30 meals. I get it. Right. And so there's more detail. Like the payments are very detailed, but there's more detail to gather. Another really interesting thing is that there's a lot of data within this fields within this data that's very interesting. So, for example, something that you can't see unless you download the data and know where to look is third-party payments, meaning
What is that?
money that's being paid either directly or paid in cash or in kind through an entity. Right. So a lot of times some providers will just say, I want you to donate this to the university. And so you'll see that. You'll see a donation to a university on behalf of that NPI. And it could be payments for services other than consulting. It could be sometimes it's even food. Like, it just depends. But what's also interesting is that you see a lot of providers who have legal entities that they've registered where they're receiving compensation. And what's interesting is that organizations that expect providers to disclose any kind of outside relationship like that are going into open payments and seeing they have providers that have legal entities that are receiving in-kind or direct payments on their behalf. And they're like, we didn't know you had a consulting company. And maybe it's just like an LLC that's formed for the purposes of getting this data for either for accounting or tax purposes. All totally fine. But it just becomes this question of like, this open payments data is such a unique data set, and that it allows you to compare in a real way what you're supposed to receive from your providers versus what's out there. And it's pretty accurate.
And
And
so,
actually, yeah,
in those instances where a provider has another entity set up and that entity is getting paid, is it also tied to that physician's name? I mean, if I go
it
and
is.
search for the physician, okay. So that's how
Yeah. So it's tied to the
that's how
NPI.
the organization might identify that provider has got this other
Yeah.
entity that's collecting payments.
It's all the NPI is the foundational piece. The NPI is like the social security number. And so what's interesting is that because, I mean, NPI is, everyone knows about the NPI if you're in healthcare, but it's fascinating because then it starts to be really easy to tie together all these disparate data sets around an NPI, right? You can download, like all the Medicare reimbursement data. You can, if you buy claims data, you can start to connect the dots there. And so that becomes an area of it's interesting, but it's also risky to make assumptions off that data. So, for example, we did an exercise where we looked at a large population of providers who were prescribing the drug Ozempic, and we looked at providers who were receiving or had an interaction with Ozempic within close proximity of prescribing Ozempic. And what we found was that providers who had an interaction with the company that manufactures Ozempic related specifically to Ozempic, meaning that transaction was related directly to that drug as disclosed by the company, um, prescribed most of the Ozempic versus providers who didn't interact with that company but prescribed way less Ozempic. Now, we don't know exactly what's driving that. We can't say from that data that this leads to that. But anyone who looks at a large population of providers and says, okay, 26% of these providers of the providers who prescribed Ozempic received money from the company that manufactures Ozempic specifically for Ozempic, but they prescribed close to 60% of the Ozempic. You
Yeah.
have to ask some questions there,
Yeah.
right?
Certainly
And I
there's
think that,
correlation, whether there's causation, that's another story.
right,
But I guess identifying that those transactions is the first step for asking the right questions that follow.
right.
Um,
And then we come kind of full circle back to the conflict of interest, which is like, okay, I'm an outsider. I see a pattern. Like, it might not be a conflict, but from my perspective as an outsider, it appears as if there may be some conflict there. Like, what's driving this? And it's very interesting. There's organizations that do academic detailing, and they go and they educate providers about what drugs to use in what scenarios, and they're not paid by drug companies, and there's a payback from
yeah.
academic detailing that leads to lower costs in prescriptions and higher quality, which is sort of like, if you look at these two things next to each other, what you're seeing is that I think it's fair to say that interactions with drug and device manufacturers are having an influence on providers. Providers agree that's the case. There's lots of things that influence providers. I think the question is like, from the conflict perspective, where is that beneficial and where is it not beneficial?
I suppose if there wasn't some benefit to the drug manufacturers, they wouldn't be doing it anyway.
Okay, so
So,
let's talk about the amount of money that's flowing here, and
okay,
like that question gets answered very quickly.
okay,
So the total amount of money that's disclosed by these companies every year is about, it's like around 12 to 15 billion dollars depending on the year. Okay, it's been kind of trending up. Well, it's been trending up a lot since COVID, but it's kind of like flattened out. I think we can correct this, but it was like 12.5 billion dollars or something last year. Most of that is research money or associated research money. Some of that is direct research money to the NPI, and then like between $3 and $4 billion is money that's being spent directly on providers for general payments, meaning marketing, meals,
travel,
whatever,
lodging,
all this stuff.
gifts, yes.
Exactly. Let me just ask you something. If you look at a major global publicly traded company, do you really think they're going to spend $300 million for nothing? No,
Yeah. Yeah, I mean,
it
they you
makes a
spend. I
difference.
mean, like a law firm. I mean, we have clients and potential clients, and we want to get business, and so we take folks out to eat. And the thought is that, um, even though not every meal is going to generate a lead or business, that collectively over time, that's how you generate business is through personal
Right,
connections.
right. And so I think that's fine. That's a normal part of business. It's how business is done. But I think where you start to sort of get into difficult territory is thinking about the changes that those payments have. Now, if you're at a law firm, um, you know, you're not billing back to federal government typically, although lots of law firms obviously do that. Although you
Yeah.
can't take people out
But
of business.
it's a little different
Um,
too though, because when I take a potential client out to eat, I am recruiting that specific client. When a drug manufacturer takes a physician out to eat, the drug manufacturer is recruiting the physician to use their products, but the physician has the fiduciary duty to the patient, to a third
that's right.
party that's not part of that transaction, not part of that meal,
Right.
which
And
which thus gives rise to the conflict of interest.
right. And I think it's important to talk about meals because it's easy for us to understand meals. Like as lay people, it's easy to I mean, I just had lunch, right? It was $20. I can like very easily understand that. What's different is when you start to think about when the dollars get bigger.
Mhm.
Um, right. I don't think there's a whole lot of people who are gonna say like there should be no meals from drug and device companies. Like, I mean, there's research that shows that it has an impact, but like, from our perspective, it's more like the systematic. pieces that are associated with either a high frequency of interactions or high dollar amounts. What's really interesting is that when we try and measure device influence, we actually don't we see increasing amounts of potential influence up to about $10,000 for an individual provider, and then it kind of tapers off. There's obviously going to be individual cases, but statistically, if you look at change in behavior, it kind of levels off after $10,000, which is not that much money for a provider necessarily. That's super interesting. But then on the other side of that, so if you think about dollar amounts, then you think about number of interactions. So it wouldn't be unusual for us to go to a big health system and see that they had over $30,000, just want to be very clear here, over 30,000 meal interactions in a single year.
Hmm.
Okay? AbbVie is always the winner. AbbVie is spending a lot on tiny meals, right? I'm guessing AbbVie is not spending a lot on tiny meals because they love to share the taste of Chipotle with America's healthcare world.
They're making relationships. Yeah, connections.
They are making those relationships. And what's interesting is, and I want to be clear here, we haven't specifically looked at AbbVie for this. So, these people do listen to this stuff, is that we do find that, and again, we can't say causality, but we do find that longitudinal relationships between providers and drug and device companies, and we really can measure this on drugs and prescriptions, tend to lead not only to increased, I shouldn't say lead to, are correlated to increased prescriptions that increase continuously over the course of that longitudinal relationship. So, that's what these are for. This money has a return on investment. I'll give you another interesting piece. So we look at procurement data at organizations, large organizations, and we look at open payments and we look at conflicts of interest. We have found that on average, every dollar that goes into affiliated providers leads to $7, on average, $7 of increased spend with that supplier the following year. Or I should say it's correlated to. Just want to be really clear here. Okay. Every dollar of money that comes from a supplier into that organization is correlated to $7 of increased spend the following year. And we've tried to control that for a bunch of outside trends and other things. That's a profound ROI, right? These companies know that. This isn't against the law. It's totally normal. It's totally accepted practice in our healthcare system for this to happen. And we're not saying that is wrong. And we're not saying that it shouldn't happen. What we are saying is that in our environment of limited trust, in our environment of increasing regulatory scrutiny, in our environment where the people who are paying for healthcare are looking for literally any lever they can pull to not pay or to reduce the amount of payment, to leave yourself exposed to this kind of blocking and tackling of basic just reputational and regulatory risk is a significant thing. And it's not that hard to get around this problem and fix it and mitigate the risk, right? It's not that hard to get visibility and then make the right decisions to cover yourself.
So speaking of right decisions and covering yourself, if you were speaking to a group of physicians, physicians who took money for meals or speaking engagements or whatever under general payments, what advice or what caveats, what would you tell them as a conclusion after seeing this data? What takeaways would you try to impart to them?
The first thing I would say is physicians have the opportunity to correct this data, and there are lots of mistakes in this data. And so there is and we can send a link if you have providers who are listening, but there is a period of time where providers can go in to CMS and they can see the data that's being reported for them, and they have an opportunity to correct that data. Essentially, they have to give a reason, and then it has to go back to the company, and they have to correct it. But almost nobody does this, and that is crazy because I think, first of all, I think there are mistakes in the data. Also, I think a lot of providers are having money attributed to their NPIs that maybe they're not even aware of. Um, these examples that we have are anecdotals. We don't have a lot of data on this, but we know, for example, if you ask your provider about money that they've received, they're probably not going to know about it. The amazing thing to me, though, is that data is part of a metric for evaluating them as a provider to payers.
Yeah.
And so, like, they might have incorrect. I remember a couple years ago there was a few $100,000 meals that were in open payments data, and we were
Wow.
just like, this can't be accurate. But the providers, they never corrected it, and they never knew about it.
Boy, those
And
appetizers were incredibly expensive.
yeah, it was a very expensive steakhouse. Um, so yeah, I mean, that's what I would say. I would say to providers like, hey, listen, like, this is normal for you to have these payments. Obviously, there are outliers and there are specialties and there are concentrations for suppliers that become abnormal. And the devil is in the details, like getting into the analytics of it. But what I would say is, like, check your stuff, change it if you don't think it's right,
Yeah.
or petition it and get on the record around what it was for, because you don't want to have to be, you don't want to have to be, trying to explain yourself. You want to be proactive about this stuff.
Does
And
CMS
yeah,
send like a notice to the
no,
providers, or does the company that's reporting it send notice? So they just have to be aware that the data is, I think it comes in or released, or is not
comes in
posted,
the
but
spring.
in
It's
the
reported
spring,
in
and
the
then they have
spring.
until June, into
Yeah,
June or so, to correct the data. So they need to be aware that this
yeah,
data exists, and then be proactive to go out and check it and request a correction if it's not right.
yeah. So actually, I have this. So the data is submitted by the entities between February 1st and March 31st. April 1st to May 15th is the review and dispute time period, and then review and correct is April 1st through May 30th
Okay.
for the reporting entities, and then the data is published June 30th.
Okay.
And
All
so
right.
that's what I would say. I would say, like, know about it. For providers that get a lot of money, they're supposed to have contracts and, like, legal agreements around these relationships. I think that really depends on the maturity of the company. The big heavy hitting companies typically are going to be pretty on top of that stuff. But honestly, it's the big heavy hitting companies that are not really posing that much risk. It's the smaller suppliers, the new suppliers, the suppliers that have, marginally beneficial things that spend a lot. I mean, we know that organizations with marginally beneficial devices and drugs spend more on marketing,
Hmm.
because things don't sell themselves, as it were.
All
Um,
right. So that's the advice of the physicians. What about advice to like healthcare organizations? Those folks that you might contract with to help identify and manage these conflicts of interest. What advice or takeaways do you have for them about this
yeah.
data?
So first of all, I would say, if you're not going to do anything with your complex data, don't collect it. If you're gonna collect it, do a lot of the work for your providers. Like, are you like we know a lot of systems will go to the providers and say, report to us. They really expect their providers to, like, go and, like, do a lot of manual data entry, to go and get this data and put it in a system. Like, no, that's crazy. Providers should not be doing that. That's a waste of time for them. And by the way, providers are doing this, like, multiple times a year in bad
Mm.
places. So they're just like, make it easy for your providers to provide you with a complete data set.
And
Okay,
so
that's
do
super
your
important.
tools help with this process? I'm assuming.
Absolutely. Yeah, of course. I mean, yes, we make it really easy to disclose all the stuff you're supposed to disclose. So make it easy for your providers.
Okay.
Like, don't ask them to do more administrative stuff than they're already doing, especially for something like this, which is, like, the least, like, it's the last thing anyone wants to do is disclose their conflicts, right? Make it easy to disclose. And then once it's disclosed, understand it. Take a risk-based approach. So a lot of systems, they collect thousands of these things, and then they literally go through line by line and read everything. So how do you take a risk-based approach? Well, you need to understand what's in your data. So, for example, instead of just, like, reading down, seeing a big relationship, and then going and having a conversation with that provider, like, understand more, first of all, collect structured data up front. What's the provider's role in the system? Do they have influence over buying decisions? Yes or no? Is the entity that they disclosed a business that the system does business with? If no, like, why are you focused on that? Worry about it when it becomes a supplier, right? What is the
So
nature and longevity
triage
of
the
the relationship?
concerns that you have.
Exactly. Take a risk based approach. Like, have a policy and a procedure for identifying that stuff. Also, don't dedicate lots of resources to this. This is a data problem, right? Can you just automate this so that your team can spend time on the 2% of relationships that are outliers or unusual or different for some reason that can't just be triaged and assessed? It's those relationships that are going to require more time from your leadership, from your board, from lawyers, from others. Like, you should be able to get to those things immediately without, like, oftentimes this process is like 4 to 6 months at a system. It just creates more risk for them. And at the end, they're just like guessing. This can be all done. This can be done by, you know, very small team at a major organization that is taking a risk-based approach, that has good discipline about what data they're collecting and understands what matters to them. That's the thing. So
Not only collecting the data, but if you're going to have a policy, a conflict of interest policy, you need to enforce that policy, or at least collect data which allows you to determine if you're going to if that policy is being complied with.
yeah, I think what we see is like what open payments does is it shows a bit of the reality of what's happening versus policy. And so what's happening is sometimes we have clients who are like, all right, I'm going to change my policy because it's not reasonable for me to expect, I got 40 million bucks into my affiliated providers last year. This is thousands and thousands and thousands of interactions. I know that's going to happen. So instead of trying to govern this and prevent this stuff and have lots of touch points with providers that really don't benefit me from a risk mitigation perspective, I'm just going to actually be smart about what matters. Do I have a lot of money that I'm spending on this organization? Is this behavior exposed to like government reimbursement? Like, if no, then like, what's the, worry about it later, or don't worry about it at all.
We've talked a lot about open payments. Are there other data sets out there that kind of shed light or kind of reveal what the payments that are being made to physicians or other providers?
So yes, they're not as granular and specific, and they're not as easy to understand. So one of the things that we will do is we can go and sort of scrape available data sets, research, trials, news releases, press releases, different data sets, ownership data, other things, and we can build a profile for a provider for what the public exposure to them is. And the truth is that open payments is a small slice
Mm.
of the kinds of extracurricular and outside business relationships that providers have, and that's increasing. Why it's increasing? It may be that doctors feel more squeezed by payers. They don't feel, they want more compensation for all their training and all their expertise. Whatever the reason is, there's a lot of data out there, and it's, if you know how to look for it, it's pretty interesting. So, for example, we'll go and we'll look at even just research data. Like, we'll go into PubMed and we'll mine PubMed, and we'll see that a provider disclosed relationship for one study and not for another.
Mhm.
And that's a gap that exposes that person to reputational risk, but it also has significant impact potentially on their ability to get research money in the future. I mean, everyone remembers the Memorial Sloan Kettering issue where senior leadership at that hospital had to go because they had not disclosed their relationships for academic research. Probably just a little oversight, right? But it led to a major issue, and especially for people in research, it's there. So things we're seeing in that, we see a lot of like upstart AI companies who have a lot of providers who are involved. Maybe it doesn't matter so much, but if you're a health system and all of a sudden you have a new AI software system that's saying, hey, you should buy us, we're great. And you don't have visibility into the fact that you have providers maybe who are owners or involved in consulting for that company because it's not an open payments, you're definitely very much still exposed to that risk.
Yeah, so
Um,
maybe the larger takeaway is there's a lot of data out there, and
there's a lot of data out there, and the takeaway is like it's not opaque, and increasingly the ability to pull together that data and understand it with not very much resources in a way that can both really damage providers and provider organizations, but also really help them. Like it's an arms race around data right now. Like everyone knows that, data and AI. And so it's like, stuff's out there. It's easier and easier for folks who are interested to get it. And so are you getting to it being proactive and understanding what your exposure is, or are you just waiting for the day when you get an uncomfortable phone call from a reporter or a payer or a
Or the
government
government.
entity or a board member who says,
Right.
my son-in-law had knee surgery at the hospital, and he came to me and said that one of the providers had received a lot of money for royalties related to that knee surgery. Like that's the kind of stuff that like causes a lot of pain for a compliance officer to respond to. It's just like, are you serious? Like this does not matter. But it's that kind of stuff. If you own the story and you know what's going on, it's not a big deal.
Hey,
Um,
Aaron, thanks so much. This was eye opening. I every time I listen to you, I learned something new. So thank you. If folks want to get in
Thank you.
touch with you, how can they do so?
We've got a website, www.conflixis.com. If you just Google open payments, typically our company will just come right up. But yeah, you can email me, anarva@conflixis.com, and happy to chat to folks about this super interesting. Yeah,
Hey,
thanks,
well, I
Wade. Really
appreciate it.
appreciate it.
Well, thank you so
All
much,
righty.
Aaron.